Good afternoon, everyone, and welcome. I'm Scott Leitz. I'm a senior fellow with NORC at the University of Chicago, and I'm joined by my NORC colleagues and our partners at Spire Healthcare Strategy for the webinar today. NORC and our partner, Spire Healthcare Strategies, are operating the Medicaid Managed Care Organization Learning Hub, funded by the Robert Wood Johnson Foundation. This is the second in a two-part webinar series designed to disseminate information to the field and on Medicaid and Medicaid managed care basics. Our other partners on this project include America's Health Insurance Plans, the Association for Community Affiliated Plans, Community Catalyst, and Families USA. Through our early discussions with various organizations, we have learned that among many stakeholders, there is an interest in learning more about Medicaid fundamentals as they are more and more involved in Medicaid and Medicaid managed care organizations. Just a few basic logistics before we get started. We want to note that all attendees will remain on listen-only mode, but please send us your questions using the chat box. We'll have two Q&A breaks during the presentation today, so we hope you'll be active in sending in your questions throughout the presentations. Today's webinar will focus on two topics: Medicaid managed care organization authorities and managed care organization engagement strategies. Each segment will last about 30 minutes, including a few minutes at the end for Q&A. You can find the slides for the presentation today, for today's presentation, and the recording of the slides from our prior presentation on Medicaid basics and Medicaid managed care financing on our website. Our first presenter today is John McCarthy. John is a founding partner at Spire Healthcare Strategies and a former Medicaid director in Ohio and Washington, D.C., as well as formerly the National Association for Medicaid Directors, Vice President and Medicaid Consultant. John, can I turn it to you?
Yes, thanks, Scott. Thanks for having us. Everyone said, as Scott said, this is John McCarthy, founding partner at Spire Healthcare Strategies. We've had two webinars so far, overview of Medicaid managed care and Medicaid managed care financing. I'm going to start today with introduction to managed care authorities. So, why are managed care authorities important? They're important for a number of different reasons, but one of them is to understand the parameters of how a state can implement managed care. It's not that a state can just come up with whatever they want to do. There are federal rules around what can or can't be done. They also enable states to design unique programs that can't be done in the normal fee-for-service world. States can use several different types of managed care. It's really important to know which type of managed care that they're using when you're going in to talk to a state, because not all managed care is healthcare services, and we'll get into that a little bit later about what's going on. Also, not all managed care is risk-bearing, meaning that not all of the contracts are at risk for what the services are being provided. So again, what's really important is that a state can do this in a number of different ways, and if you're going to work with a state or want to talk to a state, it's important to know what they're using and how they're using managed care and what authorities that they're using to implement managed care. So one of the things that people often don't realize is CMS does define what managed care is. It's first defined in law, which obviously Congress and the President put into place, but then CMS also has rules that go around that, which we'll get into a little bit more. But so this is a part of how CMS defines the parameters around Medicaid managed care programs. And this is what's really interesting. This is from the CMS website here. But obviously one of the first things they talk about is it's a healthcare delivery system organized to manage cost, utilization, and quality. So they actually talk about that. And what's important here is they specifically point out it's the managed cost, utilization, but also quality. So quality is a big piece of this one, as we'll be talking about as we move forward. Also, what's also important about this is that CMS specifically says they want to see improvement in health plan performance. They want to see improvement in health care quality and outcomes and key objectives of the Medicaid managed care program. So these are all things that as you're looking to engage with the state to talk about these different pieces, it's important to know that's what CMS is looking for, and then in turn what states are going to be looking for also. So when the state says, hey, we want to do managed care, how is it that they implement this? Well, they have to get authority from CMS to do it, and there's actually 3 methods of doing this. There's now state plan authority. There didn't used to be, but through the Section 1932A of the state plan, a state can implement managed care. You can also use Section 1915A and B waivers to implement managed care. And lastly, the way that originally started out was you needed an 1115 waiver, which was the most complicated way to do it. So states are using all 3 of these. In D.C., where I was Medicaid director, and in Ohio, I used a couple of these. I used 1915 and 1932 authorities, and we'll get into a little bit later of why would you use those different ones. So, as I talked about before, CMS has rules on managed care and how it can be implemented. Specifically, they're at 42 CFR 438. So I want to tell you one thing about this. People often ask, like, how can I learn about CMS and the Medicaid managed care program, or just Medicaid in general? One of the easiest ways to do it is actually go read the rules. So if you go read the rules in those sections, it's going to help you understand what's going on. But in the rule, which actually was recently revised by CMS, they define the program, participating organizations, functions, the different types of contracts and financial requirements. They also provide guidance to states on how to operate the managed care. And again, it serves as the basis of how states can implement the managed care program. So specifically, we're going to talk about some of the key definitions in managed care. So one of them is around organizations is, what is Medicaid managed care? What is an MCO, a managed care organization? So it means an entity that has or is seeking to qualify for a comprehensive risk contract and is a federally qualified HMO that meets the advanced directive requirements, or any public or private entity that meets the advanced directive requirements and is determined by the Secretary to also meet the following requirements. So we'll talk about there. What's interesting is this issue around advanced directive requirements. It's not something that you normally would think, that would be important in CMS rules and regulations, but it's in there. And the advanced directives are specifically around end-of-life issues and how those are, how a plan must be able to understand what those are and implement what's there. So when you think about managed care organization, MCO, that's probably what you think about normally for a typical Medicaid managed care program. However, there's 2 other types of organizations that a state can use. One of them is a prepaid ambulatory health plan. And what that really means is it is a managed care entity, but it does not have a comprehensive risk contract because it does not include inpatient stays. It specifically includes everything but inpatient stays, and it can be used in a number of different ways. One of the examples for this one is for a non-emergency transportation broker, an NEMT broker. In that scenario, you use the authority of a prepaid ambulatory health plan to implement that type of a program. Another example of that is some states, Tennessee and Ohio is pursuing this authority too, for their PBMs. So the PBM is going to be a standalone carve-out, and they're going to use this authority to be able to do that in their managed care programs. Another type of authority that you have is a prepaid inpatient health plan. In that scenario, it does provide services to enrollees under the contract with the state, and they pay for inpatient and other institutional services, but it's not a comprehensive risk contract. So they might pay for inpatient, well, not might, they do pay for inpatient and some other services, but not comprehensive services. Examples of that are some of the programs in states like Wraparound Milwaukee. That's an example of a prepaid inpatient health plan where the entity is responsible for behavioral health services for kids. Specifically, they're doing the inpatient work and then some of the behavioral health work for the kids. Another type of entity that's out there is a health insuring organization. This is basically like an MCO, but it's a publicly owned entity. So you can think of it like that around how the program is being implemented. So those are kind of the big groups of entities that you think about managed care. Here's another one that comes up, and you don't hear about it as much, but especially since North Carolina changed. But North Carolina used to use the primary care case management entity. In CMS terms, That is managed care. So if you saw our first webinar and you saw the number of states that use managed care, they would include states that use a PCCM in their delivery of services. Oklahoma is another state that uses PCCM. There's other states that use PCCM also. Again, the importance of this, of understanding the different types of organizations, is if you're going to engage with the state to talk about whatever it is that you're doing and you would like managed care to do something different, you need to know which type of organizations are out there, and can they actually use your services, because are they a part of what is being delivered. So I want to get back to a little bit around contract types and what does it mean, specifically around risk and non-risk contracts. Because this is really important when it comes into what are the incentives for a health plan when it comes to the services that are being provided. So the first one I think we all think about is a comprehensive risk contract. And what that means is that the contract covers inpatient hospital services and at least 3 or more of the following services in this list right here. And that's what creates a comprehensive risk contract. Remember earlier when I talked about the PAHPs or PIHPs, those are not comprehensive risk contracts. So they're a smaller subset of it. It still can be at risk, just so I understand. You can be at risk, it's just not a comprehensive risk contract. So you've got the comprehensive, which includes inpatient plus at least 3 of those on that list. So you can also have non-risk contracts. You see that this is defined here. So yes, in managed care, states can implement the program without a risk-based contract. So that's something to take into consideration. Again, very important when you're talking to a state to understand what type of a contract is being used in that and what are the incentives around that. Lastly is a risk-based contract that is not comprehensive. That is, for example, back to what I was talking about around an NEMT broker, non-emergency transportation broker. And that scenario, that NEMT broker will be at risk, but they're only at risk for the service they're delivering, which is transportation services. That could also be used for other things. So for instance, the example I brought up earlier around pharmacy benefit managers, PBMs. In that scenario, that contract could be either at risk or not at risk. It's up to the state to decide on how to do that. Again, the important part about understanding this is whatever version that the state implements, whether it be a MCO or PHP or PIHP or PCCM, any of those, you can have an at-risk or not at-risk contract or something in between on that. So it's important to understand what's going into that piece of it. They also have key definitions around various financial provisions. And I'm sure one of the things that you hear about a lot is actuarial soundness, which we'll talk about in a second. Before you get there, though, they have to define what an actuary is. And basically, it's an individual who meets the qualification standards established by the American Academy of Actuaries. So CMS does point to that academy to say that's who's in charge of deciding who an actuary is or not, and do they meet the standards around that. It's not like CMS goes out and certifies actuaries themselves. They rely on that outside board to do those different pieces. Something else that's very important is what is a capitation payment? Capitation means that the state is making a periodic payment for a beneficiary and the services that they're getting. So sometimes that's a question that comes up around, well, how is this paid for? You're not specifically paying for all the services, right, on a service-by-service basis. You're paying a set amount for services, not dependent on the number of services the person receives. Here's the one you probably hear a lot about when it comes to managed care, especially around definitions, and it's actuarial soundness. Here we list out what's in the rule, and you can go back and read some of these different pieces. But what's important about this is that actuarial soundness really is based on the analysis by actuaries who are licensed, and by the board we talked about earlier. So it's their opinion of what is going to be actually sound or not sound in these different areas. The rates have to be actuarially sound. That's one of the issues that you often see with managed care. So, what does that mean? Well, one of the things that it means is that a plan has to be able to operate relatively, has to be able to operate with the capitation payment that's paid to them for the services that need are to be provided. A state cannot just come up with whatever number they want and say, hey, we're going to do this for $200 and you got to provide all the services for that. That can't be done. It has to be based on sound principles, looking at prior period costs and understanding what the actual costs in the state are. So actuaries work with the state to come up with what an actuarially sound rate would be for the services in these areas. The other issue around this one is that the state has to get all rates approved by CMS. So CMS does take a look at actuarial rates, looks at the rates that are submitted, that are certified by the actuaries, and certifies that if they're good or not after they do their review on that one. So with that, that's a very high level review of authorities within Medicaid, and would love to open it up for questions.
Thanks, John, and thanks for that great overview of authorities. A complex area, but you captured it extremely well in a really concise amount of time. A few questions that have come in. The first one is the following. It says, in a recent state Medicaid director letter, CMS seemed to be discouraging the use of 1115 waivers to establish their various managed care programs, but rather pointing them to use the flexibilities of 1915B waivers. Do you have any thoughts on this question or understanding what the reasoning might be behind this?
Yes, this is something that CMS has been pushing, not only in this area, but a number of different areas where they're leaving 1115 waivers to be used where it's something that is experimental that hasn't been used before. States have been doing managed care for a long period of time, so it's no longer the idea of managed care as experimental. It is something that is known and is used by the majority of states. So because of that, there's the two other authorities that we talked about, both the 1915 A and B authorities and also the state plan authorities. CMS actually pushes a lot of states, if they can, to use the state plan authorities, which can be used for covering some of your very general groups like kids and parents. You do have to use the 1915 A and B authorities if you're going to cover some of the other more complex populations, like some of the age-blind and disabled populations. You have to use one of those waivers. The other issue that comes up around that is when you're doing the 1115, there's a theory about in the 1115 you have to propose why it is that you're doing this, and then also there's an evaluation. Well, managed care has been evaluated so much that using a 1115 authority for that really doesn't, in CMS's eyes, make sense anymore. So they really want a state to use one of the two other authorities so that you're not going through the evaluation portion of that. Now, if there's other things, Scott, that a state wants to do outside of managed care, that's where that 1115 authority often comes in and is needed.
Great, that's a great explanation. And just a reminder to folks, if you have questions, please type them into the box, and we'll try to get to them. John, second question that's come in relates to trends that we're seeing, and the specific question is, what do you think are some of the trends in federal flexibilities that states are seeking via these waiver authorities with respect to Medicaid managed care organizations?
So what you're starting to see is some of the different pieces I alluded to. There's only one state that currently uses the PHP, the model for the PBM for the state, the Pharmacy Benefits Manager, which is Tennessee. Ohio is looking to do the same thing. So in Ohio, the pharmacy benefit was carved into managed care. They're moving to carve it out, but they didn't want to go to just the old fee-for-service model for various reasons. Instead, they're going the PHP model. So I think you're going to be seeing states look at that model to say, hey, is that something we can do? One of the reasons for going to that model is because of 340B pricing. So specifically for 340B, if you're in a fee-for-service model, a fee-for-service carved-out model, there is a federal rules and law that specifically says how 340B entities can be paid and who gets the savings around that. Those same rules don't apply under managed care. So thus, you could use the PHP model, the managed care model, to be able to pay your 340B entities differently. So that's an example of how some of the authorities are being used differently right now.
Great, thank you. One additional question's come in, and it relates to something I think that's on everyone's mind right now, or a lot of things that states are really thinking through right now in light of the year that we've had. And the question is, given concerns about structural racism and inequities in health that are built into our healthcare system, are there ways that these authorities can be used by states to address health equity, for example?
Yeah, that definitely is a topic that is at the top of everyone's mind right now. And they definitely can. One of the things that can be done is with the various authorities. And if you want to go all the way in, you would look at an 1115 authority to not only implement your managed care program, but other programs around that. So is there something special you want to do or additional funding that you're looking for that you could look at to address some of the health equity issues that are out there? So is it something that could be done around the recruitment of additional providers with different racial or ethnic backgrounds? Is it enhanced rates around providers of like that? You can also use the other authorities in manners of managed care, meaning in that you could change from a fee-for-service program where you may not be able to define or say, here's the providers we're going to use, move to managed care, and with your managed care contracts, be able to work with the managed care plans to address this issue specifically, again, on recruitment of providers, helping to identify providers, and bringing additional providers into the network for people to get services.
Great, thank you. And as we mentioned, we know that's on a lot of folks' minds now, so I think that's a real great thing to be able to add to the discussion. I think that are the questions that have come in on this first segment, so I think we can move to the next portion of the presentation. I want to thank everybody for the great questions that have come in so far, and please do keep them coming along. We'll turn to our next speakers and topic then. Tom Betlock and once again John McCarthy will be our speakers for this next section. And both of them will be discussing strategies for community-based organizations to engage with and partner with managed care organizations. Tom, who we haven't yet introduced for this particular webinar, was the Arizona Medicaid Director from 2009 to 2019, and prior to that was the program's Deputy Director. Tom also served as President and Vice President of the National Association of Medicaid Directors. During this segment, Tom and John will address Medicaid engagement. In this part of the presentation, we will discuss opportunities and approaches for managed care plans, states, and community-based organizations to work together to better address the needs of the Medicaid population served by managed care organizations. We will provide some thoughts about how CBOs can work with states and managed care organizations and how to address challenges that may arise. With this background, Tom, can I turn it to you?
Thanks so much, Scott. It's great to be with everybody today and talk about this important topic. And clearly, we're seeing the growing importance of collaboration and partnership between the Medicaid program, Medicaid managed care organizations, and community-based organizations. Clearly, there are different perspectives on how to collaborate. Today's presentation is from a state Medicaid leader's perspective. We hope in the future to be able to showcase lessons from MCOs and CBOs. When you look broadly at these three organizational types, state Medicaid programs, Medicaid managed care organizations, and community-based organizations, they often share similar goals. We have similar missions of service that's often serving the same populations. One of the areas we plan to touch on today is the importance and ability to try and build alignment around these shared goals. Another is to get a better understanding of ways to build stronger partnerships by leveraging state strategies that can further collaboration. Partnerships can be educational. I have a better understanding of what your organization does. Referral and bidirectional, going both ways. You're connecting populations to my services. Or contractual, and I see that as an evolution, and contractual would be involving resource contributions. We see partnerships forming around important issues like housing, food insecurity, and justice-involved populations within the space of the Medicaid program, Medicaid managed care organizations, and community-based organizations. There's many different definitions for community-based organizations. One that seemed simple and straightforward was that community-based organizations are nonprofit groups that work at a local level to improve life for residents. This includes organizations like social service organizations, food banks, housing support organizations. And these are organizations that are often providing services that are addressing social determinants of health. And while the research around social determinants of health have been around for decades, over the last few years, we've heard Medicaid directors talking more about social determinants, community-based organizations, and Medicaid managed care organizations than ever before. Why is that? We highlighted many of these reasons in our first webinar. One is the growth in the Medicaid population, nearly doubling over the past decade. The second is the significant growth in the adult population with the ACA, a population that often has complex needs. The third is the growth in program costs and looking at more strategic ways to manage that growth. The fourth is looking at improving outcomes. And the fifth is the growth in the use of Medicaid MCOs for complex populations like individuals requiring LTSS and individuals with serious mental illness. Given all these factors, it's only fitting that Medicaid programs and MCOs would look to partner more with CBOs as aligned partners to improve outcomes for the Medicaid members that we serve. Setting the goals for engagement. There's a great quote from Edward Deming. Every system is designed to get the results it gets. And system design matters, and Medicaid directors are focused on system design issues. Given that, thinking through the importance of how the state can support better partnerships with CBOs and MCOs is an important part of thinking through new system design strategies. Partnerships are an important aspect of creating strong system design that can break down the many silos Medicaid members experience. Medicaid leaders do not have all the answers and need support in developing these new systems. State leaders, CBOs, and MCOs recognize there are significant needs for many in the Medicaid population: safe and secure housing, food, health equity, transportation, employment support. These are all areas of need that impact Medicaid members and impact health outcomes. The MCO Learning Hub has a series of papers that highlight these challenges and opportunities from the MCO, advocacy, and community perspectives. An important aspect of building a partnership is attempting to define and quantify a value proposition for beneficiaries. Outcomes are important, and MCOs are looking for as much data as possible that document impacts for Medicaid beneficiaries. In addition to outcomes, recognizing the levers that state leaders have at their disposal is critical. This includes contractual requirements and resources, both of which we'll spend more time digging into over the course of this discussion. The MCO Learning Hub featured a spotlight on Circle the City, which started as an idea by Sister Adele O'Sullivan to serve the homeless in Arizona. Starting from donations that Sister Adele kept in a shoebox, over the years, Circle the City has grown into a nationally recognized healthcare organization that serves more than 10,000 individuals experiencing homelessness across Maricopa County. An important part of the growth of this community-based organization evolved from the partnership that Sister Adele developed with the Medicaid MCOs in Arizona that worked with CTC Circle the City over many years to develop and evolve new programs. So I use that as an example of an organization that was able to identify a value proposition, identify a way to improve outcomes, and to use some of the levers that's available within the Medicaid managed care organization space to evolve how they can serve the Medicaid population. And with that, I'm going to turn it over to John for a few slides. So John, back to you.
Thanks, Tom. Now we're going to talk about how to engage with an MCO. This is something that's come up in our project. As Tom was talking about, Medicaid directors are looking to deliver different types of services. How do you engage then with the entities that deliver those services? Well, we've heard in talking to CBOs that they're somewhat perplexed because they think they offer a service that definitely could help, but they can't figure out how to engage with a managed care organization. Or they've talked to a managed care organization and they seem to not be interested in what they're having to offer. So we're going to talk a little bit about that process and how to engage. So one of the things to make sure that you understand is a state's landscape and its critical partnerships contracts with the Medicaid MCOs. So each state has its unique program of priorities and regulatory environments. Just because you know one state doesn't mean you know another one. So that's really, really important. Every state has different budgetary constraints for their program. The Medicaid populations vary state by state. And what's most important is you understand the state's priorities and environment. That can better position you for potential engagement. So, for example, on this one, if a state's priority is their children's population and what you are doing focuses on the adult population, it's going to be harder getting somebody's attention with that type of conversation. So how do you learn about the landscape? How do you learn about what's going on and what a Medicaid director cares about, governor's office? So one of the things you really should do is look at the publicly available data that's out there. So many Medicaid agencies have a strategic plan. It's often on their website. If it's not within the Medicaid agency, it might be in a larger umbrella agency. So you need to take a look at those and see what are the priorities in there. Another area to look is the MCO contracts. The contracts, again, are usually online. They lay out the expectations of what the state is expecting the managed care organization to do, and it sets out written requirements of what needs to be done in those areas. Another area to look is when a state is going out to bid for the managed care companies. So you're looking at requests for proposals. In there, states will point out what they're looking for moving forward. So sometimes in the RFP, it's different than the contract because they're asking managed care plans to come up with new ideas in an area. So they may be saying, what do you propose around prescription foods or food as medicine? So they're not going to specifically state, the state is not going to specifically say, here's a requirement, this is how you're going to do it. They're just saying, what is it that you're looking to propose? So that's an area that definitely should be on the lookout for. There's other areas you can look at too. Some states have public meetings specifically with the State Medicaid Advisory Committee, the MCAC. There could be discussions in there. And then also look at, the various Medicaid directors' presentations. Some states put those online. If you're at any of the conferences, you could see them talking. But in those scenarios, the Medicaid director usually they're talking about this is what we're looking at going forward in these areas. I want to go back to this one because this is something as Medicaid director where I was in Ohio and D.C. and Tom in Arizona and our other partner Darren Gordon in Tennessee, we ran into all the time, which was an entity would come in to talk to us and they just would not understand our state. They wouldn't know what's going on there. So you have to remember that it's not homogeneous. They're not all the same. So you've got to do your pre-work to understand what services are being provided. Is it carved in? Is it carved out? In the example we have here, this is an issue that would come up in Ohio when I was there. When I was in the beginning, we did not have mental health services carved in. They were all carved out. So to come in to try to engage with an MCO around mental health services and how you're going to help the person get mental health services may not be something they're looking at because it was carved out. So they really weren't interested. They're not even getting paid for it. So it's important to understand what services are carved in and carved out. Same thing around populations. You need to make sure when you're going in to talk to an entity, you understand which populations the programs serve and which ones don't. And is it in a separate entity? So going back to another example, in Ohio, foster care children were carved into managed care a few years ago. The state now, in its newest procurement, is carving the foster care kids and multi-system youth kids out of the current MCO contracts, but they're moving it into a new MCO contract. So they're still going to be in managed care, but will be with a different entity. So it's important that you understand that of who you're going to need to talk to about that. So lastly, don't go into a meeting with a state or MCO to pitch your post-acute care coordination program when the MCO only serves parents or caretakers and babies in managed care. Like, that just doesn't make sense. Make sure you know what it is that you're going in to pitch. So how can you get your foot in the door? Like, where does this happen? One of the things that we run into sometimes is CDOs say to us, we just can't get the MCO to call us back. We can't get the engagement with them. So one of the things to do is the Medicaid directors meet with the plans all the time. It happens very often. So, we're assuming that you probably can get, in certain cases, a meeting with the Medicaid director a little bit easier. So if you can get that meeting, what you should do in that is ask for a brokered introduction. Ask to be able to meet with somebody at the plans to be able to talk about this. Our one thing that we want to say around this is don't ask for a requirement in that meeting around, hey, could you put in your contract that they must contract with us? That is something as Medicaid director often is something that Medicaid directors don't like. So when they hear that, they might shut down. That's different from saying, hey, would you put in the contract or think about putting in the next RFP or contract the idea behind what we're doing or the approach of what we're doing or the service that we have, can you put that in there? So it's more of a competition than that happens, not specifically can you name us in the contract or the RFP. Also, we've touched on this, make sure you're aligning your idea with the Medicaid agency's priorities. And most important, develop your value proposition. What is it? It needs to be more than just saving money. How are you improving quality? What is it that's going to make a difference to the people on the program? How are their lives going to be better? You also have to convince the MCO that your idea aligns with their priorities and what they're trying to do. When you meet with the MCO leadership, work to get a meeting with the decision makers. Who's the person? Try to find out who it is that's going to be making the decision on this. And then use relationships with key partner providers that you have to get into the MCO to have those discussions. So if you're working with a health system very closely right now and they've got a good relationship with the MCO, use that to your advantage going to be able to talk about that and also be able to talk about the data that you can bring with that. And that gets into the last one. Bring data that shows a clear return on investment. Compile data from the MCO's market first that you're in, and then you can do other markets. So if you're in, let's just say Kansas, and you're doing good work, bring data from Kansas. Don't bring data from Florida to Kansas if you can. Also, make sure the data set's as large as possible. I mean, obviously that just, makes more sense. It's easier for somebody to look at it and say, hey, we had a return on investment for 5,000 people rather than 5. That's something. And then also site objective analysis. Is there somebody that has, taken a look at this and said, hey, this is the way to do it? Is there a third party that's reviewed what you've done? Those are all things that are really important in trying to get in and talk to both the managed care plan and the Medicaid director. With that, I'll turn it back to Tom.
Thanks, John. Now we're going to talk for the next few slides about one of the most important aspects, and that's potential financing approaches and what are the various opportunities around funding as it relates to developing these partnerships. So, financing is an incredibly important part of a partnership, and Medicaid and MCOs and CBOs, we need to see the relationships evolve and mature and go beyond the educational and referral aspects and really go to some contractual partnerships as a way to help solidify and grow the opportunities that exist for CBOs to have an impact as it relates to breaking down those silos and improving outcomes for Medicaid members. And there are some opportunities in terms of being creative and looking at ways to try and explore a contractual relationship between managed care organizations and community-based organizations. The first is community reinvestment. So it's important to acknowledge at the front end that only some states have this requirement. So needing to understand, again, what John was highlighting in terms of the importance of understanding the dynamics that exist within your state. But some states have a requirement in their managed care contract that a portion of the profits be reinvested in the community. And typically, one of the beneficial things about a community reinvestment strategy is the dollars have a lot of flexibility. They're not necessarily tied to medical services. There are ways to invest in terms of serving Medicaid members in more flexible ways that still have to generate an ROI, still have to improve outcomes, but really can look at a broader array of services beyond medical services, traditional medical services, and looking more at the social determinants. Oftentimes, these community reinvestments are done through the plan in terms of building partnerships or using existing relationships that they have within the community. So it's important to understand what the contractual expectations are from the state, where the opportunities lie, and then meeting and engaging with those MCOs in terms of identifying community reinvestment opportunities. The next one is administration dollars. Again, MCOs have some limited opportunity here. Oftentimes, states are looking, particularly in more economic challenging times like we're heading into, to squeeze some of the administrative resources available to MCOs. MCOs are still looking for a potential ROI, but we've seen opportunities where MCOs have engaged with CBOs and done some limited investments, done some pilots, done some things to try to improve outcomes and have an impact outside of traditional medical services in serving the Medicaid population. The next item, and John touched on this in the authorities presentation, but it's leveraging 1115 waivers to be able to conduct a demonstration to show what types of impact that demonstration may have in terms of improving outcomes, reducing costs for the Medicaid population. We've seen a great example of this in terms of the North Carolina waiver that was approved to establish Medicaid as a significant financer of community-based organizations addressing social determinants of health. And I think you're going to see states be more active as we clear COVID over the next year, year and a half, in terms of being able to look at using 1115 waivers to address social determinants of health. So important states like New York, California, Arizona have 1115 waivers that are expiring, and I would anticipate those states and potentially others to include some components that address social determinants of health through the 1115 waiver, opening up opportunities potentially for that MCO-CBO partnership that involves finances. The next is foundations. Many MCOs have foundations that contribute resources and invest in community partnerships. And so this is done outside of the managed care plan. For national organizations, it's outside of the local plan. And so this can be a little bit more challenging in terms of building those relationships. I mentioned Circle the City earlier as an example that I've seen personally in terms of a CBO organization evolving and leveraging partnerships with MCOs, and the foundation was one of the areas that Circle the City was successful in terms of partnering with the managed care organizations. The next is service dollars. So service dollars often are viewed as the traditional professional services, inpatient, outpatient services. But I think we all recognize that Medicaid is a unique program that has some unique services that are somewhat non-traditional in how Medicaid's able to leverage those non-traditional services, like long-term services and supports for being able to support individuals and keep them in the community. Behavioral health has some broader definitions in some states in terms of the types of services. Looking at employment support services and housing employment or housing support services. So again, it's state specific. It's state specific in terms of what types of services may flow through managed care organizations, but understanding that there's also the complexity of, in order to receive service dollars, registering as a Medicaid provider, I recognize has a layer of complexity to it for community-based organizations. But Medicaid is a broader payer of services than many traditional commercial products or even Medicare. And then finally, I think a new frontier that we're seeing is reserves. And so again, something that we saw play out in Arizona, where one of the MCO organizations partnered with a CBO to establish some new housing units through leveraging reserve requirements. And if you missed the explanation of reserves, we covered it in our first webinar on finances, but this is in essence dollars that are set aside with the state by the managed care organization to make sure that there's liquidity. But states sometimes, again, this is a state-specific thing, have flexibility in terms of how they look at reserves and how they count reserves. The next area is value-based payments. So many states are increasing their expectations on managed care organizations and trying to transition from our traditional fee-for-service way of paying for services to more value-based payments. And under that value-based payments continuum, there are ways in which dollars can be used in a more flexible manner as you look at value-based payment arrangements that might be a per capita basis or shared savings arrangements. So it's, again, key in understanding what the state strategy is around VBP, what the state's expectations are for managed care organizations around value-based purchasing. And it's also important to recognize that providers are often on a continuum in terms of those that really are not doing a lot of work in the VBP space to those that have embraced it and maybe looking at partnering with organizations that can help defray costs and improve outcomes for populations if they're moving towards more at-risk contracts in their arrangements with the managed care organizations. And managed care organizations also have more flexibility as it relates to VBP than if a state's trying to establish a VBP framework within a fee-for-service program. And so being able to create new models, and again, I would look at Circle the City was able to create value and use a respite model for individuals in transitional housing and create that through a VBP arrangement that was then presented to all managed care organizations who adopted that respite model in terms of providing services for individuals who are medically complex, homeless, and looking for transitional housing settings. And then the final area in terms of financing opportunities is leveraging some of the new flexibility that Medicare is creating, and specifically within the dual special needs plans. So Medicare has created new opportunities for Medicare Advantage. One of the subset programs within Medicare Advantage is known as dual special needs plans. Many states are looking at dual special needs plans as a way to better coordinate services for the 12 million individuals in the United States who are eligible for both Medicare and Medicaid. And so in many states, a Medicaid plan also may have a Medicare dual special needs plan. And for an example, a state like Arizona, roughly 50% of the population is in the same plan for Medicare and Medicaid. And so under Medicare's new flexibility, there can be some supplemental dollars that are going towards more flexible benefits. And so that might include food support services for 14 days post-inpatient. And so it's important to reach out to managed care organizations that might also have a dual special needs plan and be able to leverage that as part of a way to partner and have a contractual relationship and being able to deliver services to those dual eligible members who oftentimes are some of the most complex individuals in the system. And we also provided a link to a resource document that provides a lot more information in terms of the types of resources specifically that Medicare is allowing for and the take-up rate in terms of the Medicare Advantage plans that are taking advantage of that new flexibility. So, Scott, with that, I'll turn it back to you in case we have any questions, and welcome the opportunity to talk about these topics more in depth.
Great. Thanks, John and Tom, for that great overview. And indeed, we do have some questions that have come in. The first one, John, you talked a little bit about in your portion of the presentation the importance of understanding your state's Medicaid program, understanding the environment that it operates in, and having knowledge as you go in to either talk with your MCOs or talk with the state Medicaid program about the type of environment that it operates in and what the priorities are for the program. And a question here sort of relates to that, and it really goes to this question about how do you go about finding out that sort of information. And the question is, how do you find out what the MCO carve-outs are and what population the MCO serves?
So Scott, there's a couple of different ways to do it. One of the easier ways is if you go to the Kaiser Family Foundation's website and look at the Medicaid portion of it. They often will have there what's in managed care and what's outside of managed care. So that's one place to look. Obviously, the other place to look would be on that state's website. They'll have information on that. Probably the most difficult place to look would be to actually look at the contracts that the state has posted online and reading through some of those. That would be it. But usually there are web resources, Kaiser being one of them, that hits on those topics.
Another one I would offer, Scott, is states often produce like an annual report. And in there's usually a pretty good summary of what the delivery system looks like. And so it might lay out these populations are in managed care, these populations are in fee-for-service, these services are in managed care, these services are in fee-for-service. And it oftentimes includes expenditure detail and those types of things. Not every state produces one, but for many of them that I've looked at, it often includes that level of information, but at a higher level and not having to go dig through a 300-page contract.
Yeah, it's a great suggestion, Tom. Having just looking for a few of those myself, I can attest that if you Google given state's name, Medicaid annual report, they'll oftentimes pop up. Great suggestion.
The other one, Scott, would be an 1115 waiver. The 1115 waiver also lays out in the standard terms and conditions usually a pretty good summary of the delivery system structure for the state if it's a comprehensive 1115 waiver. So again, it doesn't apply to all states, but it's another resource.
Great, wonderful. Another question's come in. Tom, you talked about in your presentation the community reinvestment requirements that your state of Arizona had, but other states. And the question is, can you give us a sense of how many states have community reinvestment opportunities, or a few example states that? And maybe if you have while answering that, Tom, give some sense of kind of how that works generally in states that do have these requirements.
Yeah, so typically what happens is it's a percentage of the overall profit amount. The managed care organizations have a pretty good sense of what that dollar amount is. In Arizona, they would have, some time period to spend that reinvestment in the state. Again, it's not something necessarily that's going to be strongly communicated or publicly produced or anything like that in terms of those resources being available, but it's laid out in terms of what the contractual expectations are. I know Oregon has this type of requirement in their contract as well. I believe Minnesota has something, but I'd want to double check that. So it's at least a handful of states, but we probably should do some more research on that and post that as an FAQ to this, Scott.
Great, thanks, Tom. Another question that's come in relates to sort of this idea of trying to get connected and figuring out who to talk to. And the question is this: it's coming from a small community-based organization that has an interest in collaborating with some of the MCOs who operate in their community. They note that MCOs are complex organizations, and it isn't always clear who exactly to call to get started on a conversation. Do you have any advice or thoughts on that question?
Yeah, the first one would be just to approach the Medicaid agency to get some insight into where they might go within the managed care organization. So John talked earlier in the presentation about, having a sit down potentially with the Medicaid director or an official within the Medicaid program. Medicaid agencies are oftentimes doing public meetings or out talking about the program in various settings. And so that's a little more difficult right now during COVID, but finding ways to at least virtually interact with the Medicaid agency to see, who they might want to contact. So, for example, in Arizona, there were individuals within the managed care organization that focused specifically on housing and justice and employment. So if you're a CBO in one of those areas, you'd probably want to be reaching out directly to the individual responsible for those types of functions within the MCO. So again, understanding sort of how the state has structured key responsibilities within the MCO, the state can help answer that. They can also help broker, some discussions with those individuals within the managed care organizations.
Great, thank you, Tom. And thanks to both of you for the great presentations today. We have reached the top of the hour. On the final slide here, I just list resources that are available where you can find the slides and recordings. The recording for this webinar will be posted very shortly. You can find the recording and the previous slides from the previous webinar that we conducted on the website as well. And with that, I want to thank everyone for joining the webinar today. Have a wonderful day.